Good afternoon. My name is Dr. Jeff Ladinsky, and we're here today to talk about vestibular rehabilitation. I'm a physical therapist working for CORA Physical Therapy here in Sebring, Florida. And what we're going to talk about today is the various components of vestibular physical therapy. But the first thing we have to define is what is vestibular therapy and specifically the components of it. Well, we have three main senses that we use when we balance, okay? And balance is simply, bear with me here, balance is simply a term that describes equilibrium. In other words, our center of gravity must remain above our base of support. Whenever this center of gravity goes beyond the base of support, then our base of support tries to catch up to it, and that's called balance. If we don't have balance, then we have what we call the F word around here. That is a fall. But we try not to use the F word here. So the center of gravity remains over the base of support. Well, in order to do that, what we have is we're going to use three main senses to do that. All right, and the first sense that we're going to talk about is the one that everybody associates with balance, and that is our inner ear. Now, the inner ear is quite unique in that it does, well, the ear does several things to begin with. Number one, it hears. So what we look for when we're looking at the model of an ear is we can see that we have what's called the outer ear. The sound gets caught in here and channeled through the canal into the middle ear. And the middle ear, this is where our eardrum and the incus and stapes and the various components of that hearing mechanism are. But we're not concerned with that. Typically, the ear is like a shopping plaza where you've got two different stores, but they really have very little to do with each other. All right, this store here may sell sub sandwiches, but our balance center is like a gas station. So the sale of subs does not affect the sale of gasoline. The inner ear, the middle ear is the hearing, the inner ear is where you balance, and that is actually located within the skull itself. So if we're able to cut away the skull, which most patients don't like when we do that, what we have here is we've got this snail-looking creature, and again, here is our hearing, because the hearing component will go into the cochlea, and it's got its own separate nerve that goes right to the brain, hardwired right to the brain. Does not go to the spinal cord, goes right into the brain, as does the balance center. We've got these three, what I call coffee cup handles, and they're hollow. And in the hollowness of this is contained a fluid. So whenever we move in any direction, the fluid moves opposite, much like if you have a cup of coffee, you push it forward, the coffee hits the back of the cup. So what happens is, located within these semicircular canals or coffee cup handles, you've got special nerve endings that cut across, almost like a sheet going across a pipe, and then the fluid will move it forward, will move it backwards, and that sends a signal to the brain, and it tells the brain, hey brain, we're moving. Now remember, this is the left ear. We've got another one. Well, I don't have a right ear here, but you have one on each side, left side, right side. So what happens now is the signal goes to the brain, and depending on the direction of movement, one of these signals are going to be a little bit stronger than the other. Okay, so that's under normal circumstances. And then in the middle, right in here, we've got this chamber, and you've got this jello pad that sits in the middle here, and in the jello pad you've got these nerve endings. It looks like grass growing through jello, and on top of the jello you've got these rocks, crystals, otoconia. Any term has been used to describe this, and this is where, when people say they've got rocks loose in their head, this is actually where the expression comes from, because when these rocks sometimes get dislodged, most of the time when they do, they are absorbed. In other words, they dilute in this fluid that's contained in here. But from time to time, big pieces break off, or a lot of small pieces break off, and they float around. And if they float around enough, they're going to come out, and then they're going to get stuck in one of these canals. Well, that's when we have a problem, because then the flow of fluid doesn't go cleanly through these chambers All right, remember, we've got a left side and we've got a right side. And by having an unequal signal, the brain doesn't like that. So what happens is if there's an unequal signal, there's a reflex back to the eyes, okay, the second sense that we use for balance. And what happens is the eyes will begin to twitch, they'll begin to flutter. And that usually lasts anywhere from 5 to 30 seconds. That's called nystagmus. So what we do with the nystagmus then is we use the nystagmus to identify which one of those 3 canals that I showed you is guilty. Let me turn you back right here, and I want to show you kind of a cool thing here. Is if you look right here at this part of the ear, and if you look at the back canal of the vestibular system, here you've got 3 canals. You've got what's called the anterior or front, the posterior canal, and then the middle or horizontal canal. Okay? The posterior canal is in the exact same movement plane as my ear. And if you look at the shape of it, it's in the exact same shape. It looks like a C, as does my ear. So oftentimes I'll use this as the model to show patients that if you've got a clog or you got a ball bearing here, what we have to do when we try to fix positional vertigo, it's called canalith repositioning. We've got to reposition or move the ball bearing back to where it belongs. And in the model, we would see that most of the time the clog would be down here, and then we would simply tilt your head in a way to kind of make all the debris go to here. Then we turn your head a different way, and then we try to get all the debris back into here where it will be broken down over the course of the next 20 minutes. Years ago, we thought it took 2 days. We used to put collars on people, say don't sleep laying down for 2 days, but over the last 15 or so years, we've learned that actually doesn't really work that well. So by doing the maneuvers we do to fix, we don't treat, but we fix this problem, we put everything back to where it belongs, and then within 20 minutes, most of the dizziness should subside. And then we give you these, what are called habituation exercises, to retrain the nerves of all these canals to fire normally again. Okay, so that's one component. Your inner ear is part of your vestibular system, okay, or part of the balance system. Your vestibular system is technically your eyes, your inner ear, and your feet. I'm going to have our camera person, Andrea, here, if you will help me out here. Actually, if you want to reverse the camera there, and then we can do this here. I'm going to get some visual aids up here. All right, so again, what happens is we have the vestibular system, we've got the visual system, and we've got the somatosensory system, which is all the receptors in our legs and our feet sending signals to the brain. Then the brain interprets these signals, puts it together, and then sends marching orders or motor signals to my eyes and to my legs on how to react. Okay, this all takes place, lots of signals at a second, and this is instantaneous. But if there's ever a problem with these signals, if there ever becomes a problem, what happens is that we have a balance problem. So you can have a visual problem that affects your balance. Try walking with your eyes closed. See which way you deviate. Your balance is affected that way. If you've got a bad knee, bad ankle, back problems, hip problems, this lends to balance problems. What I tell my therapists that I work with is that all balance patients are balance patients, but all orthopedic patients as well, they are balance patients. So we have to look at the musculoskeletal system as well to look at balance. Okay, now if we can come here, I want to show this picture right here on the computer here. And just quickly, what we have is we have a lot of confusion with who treats balance. In other words, the gray areas, what I'm talking about are these inner spaces between these 3 rings. Here's my eyes, and typically who takes care of that is the ophthalmologist. All right, they look at the physical health of the eye and so on and so forth. And then the ears, nose, and throat doctor, their domain is in the ears, of course. And then for the somatosensory or the legs and musculoskeletal system, it's physical therapists, occupational therapists. And we have interlap. Okay, so we have these three different types of healthcare professionals working to individually, but collectively, who integrates all three of these senses? Because I always challenge people, when was the last time you went to the eye doctor and they had you stand on a rubber mat and close your eyes and test your balance? And the answer is very rarely does that occur. When you go to the ears, nose, and throat, they may do that during the course of testing your inner ear. But again, it's pretty limited to that. They're not going to have you walk and turn your head. They're not going to lay you down, or they may or may not lay you down to check the movement of the crystals of the inner ear. So again, but who is going to treat all three of these things? And the answer is your physical therapist or occupational therapist that's trained in vestibular rehab. So really, our domain covers not the health of the eye. You know, the eye doctor is very, very important for that. But we look at how the eyes affect balance. And we look at how the inner ear affects balance and how all these together, the eyes and ears working together with the legs here give us balance. Okay, so this is important to understand, is that really the physical and occupational therapist is the only profession that truly brings this all together. Okay, thanks. And we're going to move on to that. So again, we talk about positional vertigo. And the first thing that we have to differentiate when we talk about someone who comes in and says, I've got a balance problem. Well, is it an electronics problem or is it a mechanical problem? And what I mean by that is the inner ear, as we had just demonstrated a little bit ago, is a mechanical issue. It's movement of fluid within the ear. That's mechanical. Electronics is your nervous system. That would be your ear sending a signal to your brain and your brain sending a signal to your eyes on how to move. Okay? Because whenever I move my head, just like this, if I'm looking at you right now and I turn my head this way, my eyes actually went the opposite way. It went to the left. And it has to go at the same speed and same distance as my head does. Otherwise, I'm going to lose you. I'm not going to be able to see you. I will overshoot and come back. And typically what patients will tell us is that when I'm walking, it looks like things are shifting. Or sometimes I feel like I'm walking on a boat. Everything is uneven. So therefore, we take that into account. So the problem may not be visual. In other words, the eyes move left and right, up and down, and on diagonals just fine. We may test the inner ear by doing the tests to see if the crystals are clogging the canals, and they may be negative. But we have to put the two together to see if they work well together. If I'm a 100-meter dash champion and my partner over here is a 200-meter dash champion, just because we're champions individually doesn't mean on a relay team we're going to win the relay race unless we learn to work together. So if your eyes and ears don't work together, you're not going to win a gold medal. So then if the eyes and ears work together, then the third component has to come in, and that's called our somatosensory, or the balance receptors in our feet and our legs. Well, that becomes important in that just because you have strength doesn't mean you can balance, because oftentimes the typical posture we will see is we'll have a forward bent posture, bent knees, and we'll see the feet almost collapse like, well, it's called pronation, but people will call it flat feet, or the arch disappears when they're standing. And usually that's indicative of several processes going on, but mainly in the hips. The hips are your center of motion in the human body. If the hips don't work, those of you that have had hip problems, you know this. If the hips don't work, you're not going anywhere. Okay? So what we look at is what's called functional lesions within the somatosensory system, and then we go to correct that, because again, if we don't correct that, it doesn't matter how good your eyes and ears are, is because we're going to defy one of nature's laws. And what that law is, the further my head is away from neutral, or if there's a plumb line coming straight down from the ceiling, the further my head is away, the less accurate my inner ear and eyes are in determining my head position. Okay? And it's funny because when I do teach this to groups of physical therapists, I'll call the therapist up and I'll have them sit and I'll have them just close their eyes and move their head 5 degrees here. But then I'll tell them, put your chin all the way down. Now lift your head 5 degrees. Oftentimes what I'll see is this. I'll see a larger excursion. and there's less accuracy because my head's here versus if my head's here. So if a patient, for whatever reason, if they've got scoliosis, kyphosis, the rounding of the shoulders, that's going to affect balance. So what we have to do is we have to start making corrections to get the head as close to neutral as we possibly can. So we're looking at these three symptoms. Okay. Now I'm going to show you quickly. We're going to come over here, and I want to show you an example of a visual problem. So what we're going to do is we're going to shake this lady's head, not violently, of course. Okay, hang on a second. We'll see if this comes. Oh, there it is. Okay, go ahead and you can do that here. Cannot play media. Okay, so we have a technical problem here. So what we're going to do here is, what we're showing is we're going to move her head quickly to one side and then the other, and then we would watch her eyes. But what we would see in this video is when we move to one direction, her left, the eyes would lag behind, and then we'd move the head, then the eyes would move. When we go to the other side, both the eyes and head move together so the eyes stay fixed upon the examiner's nose. That's what they're looking at here. But anyway, I just wanted to do that. But because of technical difficulties, we're not going to be able to look at that. But anyway, we have those three components of balance here. And what a physical therapist who's trained in vestibular rehabilitation will do is, again, look at the individual senses and then collectively put them back together in an order, eyes going with the inner ear, and then the eyes and ears going with the balance of the extremities, the feet, and so on and so forth. Now, people that have trouble in their feet, such as neuropathy and other problems, tend to substitute. And what they substitute with is they'll use their hand. In other words, they'll come into our clinic, and what they do is they touch walls and furniture just so that they can get extra bearing on where they are in space, because their feet can't give them that. So what we have to work on is maximizing what they do have in their ankles and feet, as well as improve the reaction of their eyes. Because what I see oftentimes is, or I tell people, is you can't make your inner ear work any harder. You can't go balance harder. Well, you can't make your ear do that. So what happens is you can make your eyes quicker, or your eyes can respond faster to movement. The strongest of the three balance senses we have is actually our visual sense. We can say that both clinically and anatomically. Anatomically, there are three wires that come from the brain that are hardwiring it directly to the brain. The inner ear has two. Okay? So that tells you right there the importance of the eyes. So those nerves tell us anatomically how important that is. So we try to include the eyes. If you're not including the eyes with balance problems, then we might be missing a large component of the problem. Now, we can look up and recite all the statistics. The most common complaint in balance is what's called BPPV, or benign paroxysmal positional vertigo. And that's when the rocks or the crystals are not all in here, but they're clogging one of these canals. That's the most common. Okay, in most seniors, 50% of balance problems is usually due to BPPV. Again, fortunately, that's one of the most common, and it's one of the easiest to fix. Because like I said, we just tilt the head in certain directions to try to get gravity to pull the crystals down to here and then around and put it back in here. But the key is trying to figure out, is it the back canal, is it the middle canal, and is it the top canal? And a trained therapist will be able to tell you based upon the bouncing of the eyes. If it goes up and over, it's this back canal. If it's going across, it's the horizontal canal. And if it goes down and under, it's the top canal. Okay? That's how we tell, a little trade secret there. It tells me which side, because the eye always beats towards the ear that's in trouble, and then the direction is based upon the eye movement. So then we set you up in various positions. Now, the most common one that most people are familiar with is called the Epley's maneuver. And the Epley's maneuver has been around since the early 80s, named after Dr. Epley. And it is a very effective treatment for posterior canal BPPV. So you have to have posterior canal BPPV for it to be effective. If you don't, Epley's is not going to be as effective. Now, 90% of your cases are going to be the posterior canal. Well, that's good. If you're going to Las Vegas, you want those odds. But 8% of the time, it's going to be in the middle canal or this horizontal canal. And unfortunately, Epley's will not work. So there's different types of maneuvers that will help remove the debris from this canal. One of the problems that I find with Epley's are people that have neck problems or that have decreased range of motion and or other cervical arthritis. Epley's, you have to get the head back about 30 degrees. And for years and years, what we would do is we put a pillow between the shoulder blades to help, instead of all the backward bending occurring in the neck, it would come through the upper spine. But there's some new techniques that have been out for a few years now that have actually shown the same efficacy rate as Epley's. And instead of laying backwards, which I'll demonstrate on myself, if Andrea, you can come here. Epley's, typically, we would turn the head and bring it like this and extend back. Well, again, the problem is my neck is in a lot of extension, and there's a anatomical feature called the vertebral arteries going through my spine into my head that sometimes, if I pinch those off, can lead to other neurological signs. So I don't want to play with the vertebral arteries or my carotid arteries by extending my head back so far. So the technique that we tend to favor here is it's just a sideline test. And instead of bringing my head back, I'm just going to turn my head this way because I want gravity to pull on my ear. So I'm just going to turn my head, and with the help of the therapist, I'm going to lay on my shoulder and I'm going to look right above me. It's the same position as Epley's, but I don't have any backward bending of my neck. It's much safer. And if my neck doesn't turn, what we can do is we can just roll the shoulder. And we can get the exact same position, but instead of forcing the neck back, we can just rotate the body. It's a lot easier on arthritic necks, and that's called the sideline test. And oh, here comes a trade secret. Our tests are actually the beginning of our treatment sequence. So we would go right into the treatment sequence if we saw a positive test, the eyes bouncing. So that's how we determine benign paroxysmal positional vertigo in the clinic. Now again, that's the posterior canal. What if it isn't the posterior canal? Well, the sideline from this position is simply just aligning the canal, the horizontal canal directly with gravity perpendicular. So we would hold the head here and I would see the eyes bouncing. And then we would begin treatment if we had a positive test there. Again, we don't use the Epley's maneuver. We would do a different maneuver, and the one we favor is called the Kurtzer maneuver, which again holds the head in a neutral position. I can use the body to achieve the gravitational positions I need, and it's much safer on the neck. So that's what we tend to favor here. But that's for BPPV, the most common vestibular problem in people over the age of 50, 60 years old. Okay, vestibular problems are quite common. It's the third leading reason why people go to the doctor if their age is 65 and over. Third, okay, this is behind cardiorespiratory problems as well as back pain. So dizziness is catching up or is almost on par with back pain. So a lot of our seniors, this is why they go to the doctor. And again, it's important that when you have the diagnosis of BPPV or any other vestibular diagnosis, it could be as simple as dizziness, it could be what's called neuronitis, Meniere's, any host of diagnoses that the physician would give you, is that you seek out a therapist who's trained in vestibular rehabilitation. Okay? So, again, my name is Dr. Jeff Ladinsky. I'm a physical therapist with CORA Physical Therapy. And this has been a little bit of a primer on vestibular rehabilitation, how we identify it, how we use a differential tree to get us to the conclusion of where's your dizziness coming from. Is it coming from your eyes? Is it coming from your ears? Is it coming from your postural muscles? Or is it the combination of all three? Somewhere in there we'll find that problem. So I thank you very much for your time.